Hello everyone, my name is Gabriel Cabanilla and tonight I'm going to be talking about long-term use of ticagrelor in patients with a prior myocardial infarction. To start with, I'm going to talk about what is myocardial infarction. And this can be defined in three words. Myo, that means muscle, cardial or cardiac, that means from heart, and infarction, that means the death of a tissue due to a lack of blood. Well, the term so means that it's the death of a muscle or a cardiac muscle uh, due a lack of blood. And this could lead to a more dangerous issue that could be the ischemic cardiomyopathy. What is ischemic cardiomyopathy? Is when the heart, the ability of heart to pump blood is decreased because the heart main chamber, main pumping chamber, that is the left one, it's enlarged, dilated, or weak. This can be caused by ischemia, that it's a lack of blood supply from the heart muscles caused by a coronary artery disease or a heart attack. But this video explains it in a better way.
Hi, I'm Dr. Prabhakar Shetty. I am Chief of Cardiology at Columbia Asia Referral Hospital, Yeshwanthpur, Bangalore. Ischemic cardiomyopathy refers to weakening of the heart muscle due to blockage of the coronary arteries. So this is usually patients develop heart attacks and more than one attack or blockage of more than one coronary artery leads to depression of the heart muscle function. And this is actually measured by ejection fraction. Ejection fraction refers to the volume of blood ejected by the heart during each heartbeat. Normally this is around 55 to 65%. That is, if the heart volume is 100 ml, 65 ml or 60 ml of blood is ejected in a normal healthy heart. This is called ejection fraction, and in patients with depressed heart function, this is depressed. So it will be lower than 55%. So in ischemic cardiomyopathy, for example, patient may have an ejection fraction like 25, 30 or 40%.
And knowing this, what are the applications of ticagrelor in medicine? Well, there was a study specifically called Pegasus TIMI 54 that that tells the doctors that ticagrelor at doses either at 90 milligrams or 60 milligrams can significantly reduces the risk of a composite of major adverse cardiovascular events by a 15 or 16% in stable patients at high risk with a prior myocardial infarction of 1 till 3 years earlier. And this video can prove it.
Pegasus TIMI 54 demonstrated that long-term secondary prevention with ticagrelor reduced cardiovascular death, MI, or stroke in patients with a prior myocardial infarction. Now, as we look at the data, we're trying to understand the efficacy and safety of long-term secondary prevention in important subgroups, and one of those subgroups are patients with peripheral artery disease. It's important that this population in Pegasus is a population of so-called polyvascular disease. They've had both a prior myocardial infarction and peripheral artery disease. And we know that those patients are at heightened risk of ischemic events, including limb ischemic events, heart attacks, mortality, and bleeding. And so we felt it was important to understand the efficacy and safety of therapy in that population. The primary results of this analysis in the PAD subgroup were that patients with peripheral artery disease were at higher risk of cardiovascular events, so MI, stroke, and cardiovascular death, as well as all-cause mortality and limb ischemic events relative to MI patients without PAD. And that relationship with risk was preserved even after we adjusted for differences in baseline between the two groups. In terms of the efficacy and safety of ticagrelor, we found that the efficacy was similar in those with and without PAD in terms of the relative risk reduction. But because the PAD patients were at such high absolute risk, that translated into a robust absolute risk reduction of over 4% when you look at the doses combined, or with the 60 milligram dose of over 5%, and a very low number needed to treat. In addition, we found that the bleeding signal for ticagrelor was similar for patients without and with PAD. There was no difference. And we saw in an exploratory endpoint that there was a reduction in adverse limb events with ticagrelor, which was an exploratory endpoint, but something where we saw a reduction. Pegasus looked at two doses of ticagrelor. One was the 90 milligram dose that had been shown efficacious in the ACS trial Plato, and one was a lower dose, 60 milligrams, which was thought to potentially have an optimal blend of efficacy and safety for long-term exposure, long-term secondary prevention. Overall, both doses reduced events to a very similar extent versus placebo in the trial. We saw no heterogeneity for either dose based on the PAD population, but when you look at the actual endpoints, you see that the 60 milligram dose actually has significant reductions for cardiovascular death and mortality, and a more robust absolute risk reduction and relative risk reduction. And whether there are truly differences between the doses, we didn't test that in the paper. We have seen that pattern throughout the trial. The 60 milligram dose looked particularly attractive from a risk-benefit profile, and perhaps because it's a better tolerated dose, there was better adherence with the 60 milligram dose. But overall, it's very reassuring because that's the dose that's labeled for use. I think the take-home message is that in the prior MI population, if clinicians are thinking of which populations are going to get a robust benefit from long-term ticagrelor therapy, that I would say patients with peripheral artery disease and prior MI, it's one of those populations that will derive very robust risk reduction.
Okay, knowing this, what are the pros and cons of this ticagrelor? Well, talking about the pros, it's that in patients with myocardial infarction more than 1 year previously, treatment with ticagrelor significantly reduces the risk of cardiovascular death, myocardial infarctions, or stroke, and increase the risk of major bleeding. In cons, we have that ticagrelor was also associated with an increase of TIMI, major bleeding, but was not associated with an increase in an intracranial hemorrhage. This video can prove it and talk about the pros and cons.
Well, this was a very interesting study that was presented by Deepak Bhatt, and what it was a trial of a reversal agent for ticagrelor. And as you know, the newer P2Y12 antagonists are really beneficial. They reduce the risk of stent thrombosis, they improve the rates of recurrent MI, and sometimes even mortality. And so they become more and more popular for the treatment of acute MI, ACS, and PCI. The problem is that there's no reversal agent. They suppress the platelets, and then unfortunately you're prone to bleed. And current guidelines say you might have to wait 3 to 5 to 7 days before you can do surgery. So that's been a big problem in clinical practice. This randomized trial, which was conducted in normal volunteers, found that if one gives ticagrelor, it reduces platelet activity by 80%, and when they gave varying doses of an antidote, which was a monoclonal antibody against ticagrelor, they found that it completely reversed the antiplatelet effects. Happened very quickly, happened within 5 to 10 minutes of the infusion, and the results were persistent over the course of the intravenous infusion. The interesting thing is once the intravenous infusion was stopped, platelet activity went to a down just slightly, but there was no rebound effect. And that's particularly important because you don't want a hypercoagulable effect from any medication that stops bleeding.
Were you surprised by the results?
No, I wasn't particularly surprised. I'm impressed that they were able to come up with this compound, and it's going to be incredibly helpful. So for example, if I have a patient that's receiving ticagrelor and they start bleeding, I want something to reverse that, and you can't give platelet transfusions to reverse it. Also, if I have a patient that needs bypass surgery, I don't want to waste hospital resources waiting for days for this drug to wear off. So it's going to really improve the care of the patient.
Well, with this, what issue could be applied in Ecuador with ticagrelor? Well, in Ecuador, the acute myocardial infarction is placed in the first position in morbidity and mortality, reporting in 2030 1950 cases of AMI of patients graduated in nationwide, being 1,424 men and 491 women. What was reported to mortality level was 223, being 444 men and 79 women. And finally, the conclusion is that the addition of ticagrelor at doses of 19 milligrams twice daily or 60 milligrams twice daily to low dose of aspirin reduce the risk of cardiovascular death, myocardial infarction, or stroke, and increase the risk of TIMI, major bleeding, among patients who had been myocardial infarctions from 1 year to 10 years to 3 years earlier. Thanks a lot and goodbye.